It's cold, so I have allowed my patient to leave her pants on. When you do your checkout, week 9, no pants, okay? If we've made alternate arrangements, that's a different story, but no pants, okay? Because it's cold today, I let her leave her pants on. Because you guys are video recording, I let her leave her pants on. Checkout, no pants, okay? So wear shorts, biker shorts, grab a pair of boxer shorts, whatever. No pants, all right? Everything is skin to skin. So for this particular assessment, I need a pen light, my stethoscope, all right? And I'm going to be standing on this side because when we do a cardiovascular assessment, we stand on the right side of the patient. Why, you ask? Well, there's a couple of reasons, and one of which I don't like at all, and it's because that's how we've always done it. I don't like that reason. I like evidence, okay? In my research that I did, and I've had people ask me so many times, why? The only the only reasons I found were, one, because most practitioners are right-handed, so we stand on the right side of the patient. I'm a lefty. 13% of the population is lefties. But since most practitioners are right-handed, we stand on the right side of the patient. And also, when we're doing an abdominal assessment, if we wanted to palpate the liver, it's easier to palpate the liver from the left side or from the right side. Okay? So always on the right side. When you're doing an abdominal assessment, when you're doing a cardiovascular assessment, we are on the right side of the patient, okay? All right, so again, I have my checklists. Make sure you use your checklists. It's okay to use your checklists, all right? I want you to feel comfortable with this. I don't want you to memorize it right this second, so use your checklists, okay? All right, so I pull my curtain, I wash my hands. Hi there, my name is Jen, and I'm going to be your nurse today. Can you tell me your name and date of birth?
Ariana Castillo, August 2nd, 2006.
Ariana, may I see your bracelet? Ariana Castillo, August, blah, 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 blah. Thank you very much. Ariana, do you have any allergies?
Shellfish.
Shellfish. Okay, what happens when you eat shellfish?
Anaphylaxis.
Okay, we will make sure there's no shellfish. What also is starting to trigger in your head? She's allergic to shellfish. Iodine, exactly. So if Ariana needed to be catheterized, we could not use the iodine to clean her. We would have to use just soap and water. Side note, sorry. So no, we won't use any iodine around you, and I will make sure there's no shellfish in your room. Do you have any cultural considerations that I should be aware of?
No.
Okay, so I'm here to assess your cardiovascular system. So I'm going to raise the bed so that I'm not constantly leaning over you. I put down the side rail so that I can get closer to my patient. Okay, so the first thing I'm going to do is I'm going to observe my patient's neck. So I want her supine, so she is supine, she is laying. I want the head of the bed at 30 degrees, so I need to raise her head just a smidge bit more. Remember when we did bed mechanics, there is a little level on the side of the bed that will tell you how high your patient is laying. So I now have her at a 30-degree angle, okay? So I'm going to inspect. So the first thing I'm going to do is I'm just going to look. Ariana, can you tilt your chin to the ceiling? And what I'm looking for is any very visual pulsations, right? There should be a slight pulsation where her carotids are, but just slight. And if there's not, that's okay too. I'm looking for like that boom, 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 like really thick, ropey neck veins. And if you Google jugular vein distension, you'll know what I mean by thick, ropey neck veins. But I'm just looking, are there any pulsations? A slight pulsation is okay. I don't want anything like bounding in my face. So I just use my pen light. Okay, so no pulsations notated in observation of the neck, okay? And now I'm going to palpate her carotids. We only palpate one at a time, okay? Because if you palpate both carotids at the same time, you're at risk for doing two things. One, cutting off blood flow to the brain. Now you would have to palpate and press pretty hard to cut off blood flow to the brain, but we don't even want to risk that. The second thing is, if you're palpating both carotids and you're accidentally like rubbing, you might be performing what's called carotid massage, and that could put the patient into a life-threatening arrhythmia. So we palpate one at a time, okay? And we're palpating for amplitude. How strong is it? Is it weak, where we're barely feeling it? It's like, is it bounding? Is it boom, 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 boom? Okay? We are palpating for rhythm. Does it feel regular? Love dub, love dub, love dub, love dub. Or does it feel irregular? Love dub, love dub, love dub, love dub, dub, love dub, 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 love dub, love dub. So does it feel regular or does it feel irregular? We are assessing for thrills. The way I like to remember thrills is something you feel. So a thrill can feel like a cat's purr, okay? It's turbulent blood flow. So it could be like, so what I would imagine a cat's purr would feel like if it were in your neck. So we're feeling for amplitude. How strong is it? We're feeling for regularity, the rhythm. Is it regular or irregular? And do we feel any thrills? Is there a cat's purr? When you're palpating the carotids, okay? So, palpating one at a time, and being that I'm a lefty, I'm gonna reach over and palpate the left side first. If you're a righty and it's easier for you to, whatever works, but we're always standing on the right side of the patient. So, tilt your chin to your chest. I'm sorry, your chin to the ceiling. You were doing right. Okay, so it is a +2, which is normal. Her rhythm feels regular, and I do not feel a thrill. So, rate and rhythm feel within normal limits, so +2 and regular, no thrill palpated. You might not always find it the first place you put your fingers. You might have to move your fingers around a little bit, that's okay. Again, the amplitude feels like a +2. Rhythm is regular, and no thrill is palpated, okay? So we have observed, and now we have palpated our carotids. The next thing we are going to do is we are going to auscultate, and I'm listening for bruits. So I said a thrill is a cat's purr that you feel. It's turbulent blood flow that you feel. A bruit is turbulent blood flow that you hear, okay? So you would listen with the bell of your stethoscope. My stethoscope is a little different. I just press a little differently, and so you're going to listen with the bell of your stethoscope, okay? And again, we are just lightly placing our stethoscope. We're listening for any turbulent blood flow. It could sound like it doesn't sound smooth like whoosh, whoosh, whoosh. It sounds rough. Chin to the ceiling, thank you. I forgot one step. Can you hold your breath for a minute? So hold your breath and breathe and hold your breath and breathe. The reason we have our patients hold their breath is so that we don't confuse heart sounds or sounds of the blood flow with breath sounds, breathing, okay? So you have your patient hold their breath, you listen, tell them to breathe, go to the other side, hold your breath, and tell them to breathe when you're finished. So no bruits auscultated in the carotids. So now I'm going to assess, I'm going to visually inspect the precordium. The precordium is the chest. May I take your gown down? Thank you. Okay. So I'm using, can you just put your hands at your side? I'm using my tangential lighting, right? I'm using an extra light so that I can shine this light like across her abdomen. I'm looking at her aorta here, her abdominal aorta. I'm looking at the aorta up here. I'm looking for any pulsations, okay? A light pulsation, okay. I'm looking for anything like boom, 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 anything bounding. And this ceiling light up here, I mean, yeah, it's okay, but we have shadows. When you're casting a light across the side of the patient, you don't have those shadows, which is why we use tangential lighting when we're assessing for any, it's called lifts or heaves, okay? That's abnormal pulsations in the chest. So, I'm using my tangential lighting. I do not notate any abnormal pulsations, so no lifts or heaves are present, okay? And now I'm going to palpate. So a heave is a ventricular impulse. So that's almost like when I say a thrill in the carotids is a cat's purr. If you feel that when you're palpating, it's called a heave, okay? I'm just gonna place my hands on your chest and I'm just going to assess for any abnormal feelings. And we're doing it, we're palpating the chest the same way we palpated for respiratory. We're using the palms of our hands because it covers a larger surface area, and we are palpating 3 places in the front, okay? Then we are going to palpate lightly at every place that we're gonna auscultate. So ape to man, All People Enjoy Time magazine, we'll go through that in a second, but I'm gonna palpate your entire chest first. Okay. So no abnormal heaves or lifts are notated. And now I'm gonna use 2 fingers, right? And I'm gonna palpate in each of the spots that I'm going to auscultate. So A, ape, apical, is the second intercostal space, right sternal border. P, pulmonic, or persons, second intercostal, left sternal border. E, Erb's point, which is everyone, all people enjoy, or APE. So that is the third intercostal space, left sternal border. M, magazine, or M starting in man, is the fourth intercostal left sternal border. And then, could you lift your breast for me? And then the M, or the N, M is mitral. AP, I'm sorry. Fourth intercostal space is tricuspid. I jumped ahead. So fourth intercostal left sternal border is tricuspid, and if you could lift your breast. So fifth intercostal mid-clavicular, so mid-clavicle, right under the nipple, is mitral. Mitral is also my point of maximal impulse. So I might want to stay here for a little longer just to see if I can feel. This is the closest external place that the heart is to the body. It's the apex, that very point of the bottom of the heart. Sometimes you can feel it, sometimes you can't. If you cannot feel it, it doesn't mean there's anything wrong with your patient. It's not always palpable. What I can do is I could have my patient turn on their left side. I'm gonna lower your bed for a moment. And if I could just have you turn on your left side. Another way I can assess the point of maximal impulse is you stand behind the patient and same thing, you find that mitral valve, so that's the fifth intercostal space, mid-clavicular, and you would palpate that as well. And see, in this position, I can actually feel it. You don't count the pulse, all you're doing is you're looking, you're feeling if you can feel it. Thank you, you can roll back. Okay. Now I'm gonna raise her back up. Okay. So, now I'm going to auscultate. And we're gonna auscultate the same places that we just palpated. So I'm going to start at the apical impulse, which is right sternal border, second intercostal space. Now, what I should say is, there's no valve over here. But the way the heart sounds in the body radiate, this is where you hear the aortic valve. That's where it radiates to. Our hearts are on our left side, so why are we listening to the right side? Because that's where the sound radiates to. Does that make sense? Okay. I just don't want you to think I'm crazy. So, second intercostal space, right sternal border. Pulmonic, second intercostal space, left sternal border. Erb's point, third intercostal, left sternal border. Tricuspid, fourth intercostal, left sternal border. And mitral, if you can lift your breast, is fifth intercostal space, mid-clavicular, same place. Now I want to get an apical pulse. Remember I said this is the closest place to the external body that your heart is. You're going to stay here for a full minute and count. My apical rate is 74, okay? Now we are going to listen for murmurs. Murmurs, again, turbulent blood flow. It sounds like whoosh, whoosh, whoosh. You're gonna listen to murmurs on the SAMI, and it's whoosh, whoosh. It's very turbulent blood flow, okay? It might be very soft. It might be whoosh, but it could also be very loud. There are a couple of populations where a murmur, completely innocent. Pediatrics, kids are sometimes born with a murmur. By the time they hit 5 or 6, it's gone. Pregnant women can also have murmurs. By the time they give birth, could be gone. Athletes could have a murmur. No, not athletes. Yes, athletes? No, I'm just gonna stick with kids and pregnant women. If you hear a murmur, it definitely warrants further investigation. Either say to, your charge nurse, or you say to your provider, hey, I think I heard a murmur. I heard it at, over the mitral valve. Can you take a listen? It always warrants further investigation. And if it's nothing, it's nothing. Great, the cardiologist just listened and we confirmed it was nothing. But if it is something, it might need to be monitored. So if you ever hear a murmur, you want to let somebody know, okay? So you're going to turn the head of your stethoscope and you're going to listen for murmurs with the bell, okay? And you can either start at the top and go back the same way you came, or you can just reverse it and go backwards. Whatever works for you. I like to stay at the mitral valve and just go backwards. So, listening for murmurs. So I'm at the mitral valve, so that's the fifth intercostal space, mid-clavicular. Then I go to the tricuspid, which is the fourth intercostal space, left sternal border. Herb's point, third intercostal space, left sternal border. Pulmonic, second intercostal space, left sternal border. And aortic, second intercostal space, right sternal border. Everyone's anatomy is slightly different. I tend to find that when you're listening to Herb's point, which is the third intercostal space, that is where I always think the heart is the loudest, where you're going to hear the loudest and the most clear sounds. But again, everybody's anatomy is different. So, upon auscultation, S1, S2 heard, no adventitious heart sounds notated. So, S1, S2, lub-dub, lub-dub, lub-dub. So, S1, S2 notated, no adventitious heart sounds. Adventitious heart sounds could be a murmur. It could be an extra heart sound. Did you guys learn about S3, S4, gallops, and all that in class today? Okay, then I'm not going to go into it because it does take some brain capacity. But you may hear like lub-dub, lub-dub, lub-dub. So it's an extra heart sound that doesn't belong there. So if that's what I heard, I would say S1, S2 present, S3 heart sound notated, and then I would tell somebody. I would tell whoever my provider is, the cardiologist, the nurse practitioner, the PA, I would tell someone that I think I heard an extra heart sound, because that's not normal. It's not supposed to be there, okay? So if I heard a murmur, I'm going to tell someone. I'm going to tell the cardiologist. I'm going to tell the nurse practitioner. I'm going to tell the PA. I'm going to tell somebody, because we shouldn't be hearing murmurs. Pediatrics and pregnant women are the only exception. I would still tell someone in a pediatric patient or a pregnant woman if I heard a murmur. Am I right? Gab, am I right? So that's our labor and delivery nurse and our pediatric nurse practitioner. So they both say yes, but I would still tell someone if I heard it. Okay, so then, all right, let's put this back up. Now I am going to assess for any edema. So what I'm looking for is symmetry of her arms. Her arms are symmetrical, okay? The color is even. The temperature, I would feel with the back of my hands, because our palms are a little rougher. So I would feel the temperature I'm looking at hair distribution. I'm pretty much kind of doing a mini skin assessment here where I'm looking for any lesions, I'm looking for any redness, any ecchymosis. Like I can notate that her knuckles are a little red. So I would say, oh, your knuckles are a little red. She's a softball player, so she's wearing a glove, so her knuckles are gonna be red. So that could either be a point of conversation, or it can just be a point of investigation. Oh, I see your knuckles are a little rough. Can you tell me a little bit about that? Oh, I'm a softball player. I wear a glove, all the time. Or I'm in construction. I'm constantly dragging my hands through cement. So ask. Always ask the question if there is something abnormal. All right. So I'm also looking at capillary refill. So I'm going to look at my fingers, and I'm just going to press on them lightly. And what I'm looking for is, do they blanch, which means turn white, and then go right back to pink? So what's a normal cap refill?
Under 2 seconds.
Under 2 seconds. So cap refill in bilateral hands, less than 2 seconds. Arms are symmetrical, hair distribution is even, color is appropriate for age and ethnicity. I'm also, looking at clubbing. So you're gonna see clubbing most often in the thumb. Clubbing can be a respiratory or a cardiac issue. More often than not, it's a respiratory issue, but it still can be a cardiac issue because not enough blood flow is getting to those capillaries in the nail beds. Clubbing is a big, wide, fat thumb. When you see it, you know it. No clubbing notated in the thumbs. So now I'm gonna look at her legs. Okay. So we're pretending that her pants are off, but I'm looking at the color of her skin. I'm looking for any lesions, any ecchymosis. I'm looking at her feet. Now, I'm not able to check cap refill on her toes because her toes are painted. That's okay, because you really still can. If you touch the top of her toe and it blanches and the color goes right back to pink, you know that you have a good cap refill. You know that you have blood flow to those tootsies. After touching someone's feet, we always sanitize. Okay. So, legs are symmetrical, hair distribution is even, color is appropriate for age and ethnicity, no ecchymosis, no lesions, no rashes, no swelling. Now I'm going to assess for edema. Thank you. So we assess edema on a bone. So I like to press on the shin first. And what you're doing is, did you learn, you guys saw the grades of edema in lab? Okay. So you're gonna press. And what you're looking for is, does your finger make an indent? So no indentation on her shins. I also like to go on the tops of the feet and the ankles, because those are the places that you're gonna see edema most often. Now, edema can happen anywhere. There's something called anasarca, where you're pretty much edematous all the way up. Edema likes to go to wherever the lowest place of the body is. So if you're sitting in a chair with your feet down all the time and you have edema, you'll see it in the feet and the ankles. If someone is laying constantly, you may see it in the calves, you may see it in the sacrum. Now, there's something else called lymphedema, which is different than regular edema. That is a backflow of lymph fluid where it's caused by a disruption in the lymph fluid. So you may see that in one leg all the way up. You may see it in an arm. You may see that. A lot of times lymphedema is unilateral, whereas edema, pitting edema, not all the time, but a good number of the time is bilateral. So if you just see swelling on one arm, start doing a little more investigation. It might be just regular old edema, but it might be something called lymphedema, okay? So I pressed on her shin bones, I squeezed her ankles, I touched the top of her feet. So no edema is notated. Now, when I see a person that has edema, and especially +3 or +4, it's painful because it's stretching of the skin, it's stretching of the fascia, there is fluid where it's not supposed to be. So we need to grade that because we need to be able to say to the cardiologist, they have +3 pitting to their feet and ankles. They'll put them on something to help get rid of that fluid. So we need to be able to grade it. So I always apologize to my patients. I know your ankles and feet are swollen. I'm really sorry. I have to press just this once and then I won't do it again. And then I will grade what my edema is. And it is painful. It hurts. I've had to do it on my own family members and I'm like, I'm so sorry. But we need to know so that I can say to the doctor, they have +3 pitting edema. They'll put them on a med to pull out some of that fluid. And then tomorrow we'll come back and be like, guess what? It's +2. What we're doing is working. So, we need to make sure our interventions are working. So, no edema notated. Cap refill +2 in bilateral extremities. Hair distribution is even, color of skin is appropriate to age and ethnicity, no ecchymosis, no lesions, no anything abnormal. Okay, so the last thing I'm going to do is I'm going to palpate pulses, all right? And I like to start at the top and work my way down. We don't palpate the carotid for pulses. We already palpated our carotids, right? So we don't have to worry about those. So what's the next one? Is our brachial, right? So if you can, I like to palpate them together because we are, again, assessing for amplitude. Do they feel the same? We're not grading for rhythm, we're grading for amplitude. Do they feel the same? Are they weak and thready where you can barely feel it? Is it bounding, pulsating, boom, boom, boom? Then we're gonna feel the radial. Got good radial pulses. We are not physically gonna assess the femoral, but the femoral is right here in the groin, okay? We use femoral in an emergency. We'll put a Doppler on the femoral if we're doing stuff to see if we have a pulse. So that is a very strong pulse. As long as you know that femoral is in the groin, we're good. The next place is popliteal. I personally think the popliteal is the hardest pulse to find. It is the pulse behind your knee. Look at my thumbs. My thumbs are on her kneecap and my hands are wrapped around her leg. So I'm feeling for a pulse. This is the pulse where I grab the Doppler. Never use your thumbs when you're feeling for a pulse because your thumbs have their own pulse. Okay, the other side. The popliteal, you can't do both at the same time, so. Okay. And then your posterior tibial, so that's behind the tibia. So outside ankle, behind the bone, there's a little pocket. So outside bone, bottom of the tibia, little pocket. There's a little squishy pocket. That's usually where it is. And then dorsalis pedis. So pulses present in all extremities throughout, +2, okay? +2 is the amplitude. We're not feeling for regularity because I'm not gonna feel somebody's feet to say, is their heart beating regularly? I am only feeling for amplitude. So +2 pulses throughout in all extremities, or +2 pulses felt, and you can name all of your pulses, whatever. So that's, what was I gonna say about? So if a patient has a pulse in their foot, they have a pulse posterior tibial. They have a popliteal, okay? If they have an amputation, so they have a below the knee amputation, so from here down is gone, you still are able to assess popliteal, okay? You're still able to assess femoral. If they have just, you know, a metatarsal, transmetatarsal, which is half of the foot, you can still assess posterior tibial, okay? So if they have a pulse in their foot, there's a good chance they have pulses all the way up that leg. You still want to palpate, but if they have a pulse in the foot, there's a good possibility they have pulses all the way up. Now, if you're feeling the foot and you're like, it's cold, it's a little blue or pale, like her toenails or the tips of her toes are pale or kind of blue, and I'm just like, I don't know if I can feel anything, you can always get the Doppler, okay? Grab the Doppler, put a squirt of gel on, and get the Doppler and feel for pulses. And then if you hear one, get a Sharpie and put an X, and the next person will know, all right, that's where the pulse is. Either you can feel it or you can hear it, okay? Questions, comments, concerns? Speak now or forever hold your peace. Yes.
When you're listening for a murmur in the spots right here, it's with the bell, right?
Correct.
Okay.
B bell, bruit, blood flow. Yes.
I'm thinking about edema. So you said in a situation where the feet can swell up if you're sitting for too long. So will that swelling look different than, like, say, if you have an infection?
Yes. Cellulitis, that's a great question. Swelling that's cellulitis will most often also have redness and tenderness. So the tenderness and the swelling may be the same, but redness will be also present. Good question. Anybody else?
So we don't listen at the back?
No. Just for the respiratory assessment.